Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Guidance for Screening, Assessment, Intervention, and Monitoring for Suicide Risk in OASAS Certified Programs. And our presenter is Dr. Grace Hennessy, Associate Chief of Addiction Psychiatry from New York State OASAS. Dr. Hennessy will be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome Dr. Hennessy.
Thank you, Dean, for the introduction and welcome everyone. So today, as Dean said, we're going to review the guidance for screening, assessment, intervention, and monitoring for suicide risk in OASAS certified programs. I do not have any disclosures to give related to this talk. So I know that many of the people who are listening to this are working in the substance use disorder treatment field. So you're well aware that we have a serious issue in this country with drug overdose deaths. This slide is from a study that was published in late 2022, and it shows the age-adjusted rate of overdose deaths by sex and by total from the years 2001 to 2021. And as you can see, there's been a steady rise over time in the number of overdose deaths, with some increase in more recent years with the arrival of fentanyl in the unregulated drug supply. So this is a major issue that we are facing, but a similar major issue is suicide mortality in the United States. So this is a very similar looking graph about age-adjusted suicide rates by sex in the United States between 2001 and 2021. Now, we don't see quite the numbers. The numbers are greater for overdose deaths overall. But you can see there is this very consistent line that is showing a trend upwards in the total and for males and females over time. There was a little bit of a dip in 2020 in the numbers, but unfortunately the data from 2021 has shown that the numbers are sort of reaching similar levels to 2018, which was some of the highest rates of deaths by suicide in the United States. There is an intersection between substance use disorders and suicide. This table is from a 2020 study of 2,674 individuals who died by suicide in the United States between 2000 and 2013. And they found that substance use disorders were associated with an increased risk of death by suicide. So on the left-hand side, you have the substance use disorder, and on the right-hand side, you have the odds ratio. So the odds that someone with a particular substance use disorder was someone who died by suicide during this time frame. So you can see it's sort of the numbers increase for the most part, depending on the substance. So tobacco, people were twice as likely to have died by suicide. Drug, unfortunately, they didn't separate out what drugs were, so it's really all drugs. But the odds that someone who had died by suicide had a drug use disorder was 5.3, for alcohol 5.8. And then they looked at combinations. So drug plus tobacco was about 5 times, alcohol plus tobacco 6 times, and alcohol plus drug 8 times. And alcohol plus drug plus tobacco, which is something we see very commonly in our treatment population, was over 10 times at 11. With the odds of someone who had died by suicide having those substance use disorders. This is sort of a study that really just kind of looks at numbers. There's not really a lot of like why that they give in this study. They wanted to just highlight the point. But I think the point that I will highlight at the end of this is that people with substance use disorders are at elevated risk for death by suicide. One of the challenges that we're coming up against in current years is trying to determine if these are deaths by suicide or deaths by overdose. So the rapid growth of overdose deaths in recent years has led to uncertainty in the classification of deaths by suicide. Some experts estimate that at least 20 to 30% of unintentional overdose deaths may have had a suicidal intent. And the challenge is coroners and medical examiners can have a difficult time determining the cause of death because in the absence of a suicide note, the autopsy that the coroner performs, information collected at the scene of the death by suicide, and circumstantial evidence that might be there or information that's given by family or friends are used to determine the cause. So if someone dies by gunshot or hanging, they are 41 times more likely to be classified as a suicide attempt than deaths from unintentional overdose. So again, we don't know that some of these people who are dying by overdose may actually be taking their life. So again, it brings home the point again of the importance of recognizing suicide and suicide risk in our population. This is a study to kind of demonstrate this a little bit more. This is a study entitled Suicidal Motivations Reported by Opioid Overdose Survivors, a cross-sectional study of adults with opioid use disorder. It was published, it was written by Hillary Connery and her colleagues at McLean Hospital, published in 2019. And they looked at 120 patients admitted to an inpatient detoxification and stabilization unit. Out of the 120, 53 or 44% reported a history of opioid overdose. Out of that 53, 31 or 59% reported some desire to die before the most recent overdose. And 19 out of the 31 or 61% reported a strong desire to die. So again, seeing this close relationship between overdoses and suicidal intent. So because of this, OASAS has been very interested in preventing deaths by suicide as much as we are interested in preventing deaths by overdose. And the philosophy that we are embracing is zero suicide. So the Zero Suicide Framework is an organizational level initiative that works to decrease suicide rates through comprehensive screening, assessment, reassessment, and aftercare planning. The foundational belief of zero suicide is that all suicide deaths are preventable. Zero suicide requires that all relevant stakeholders take an active interest in reducing suicide in the entire agency or the entire program that they are working in. So zero suicide is something that you can look up online. They do have a website and they have some great trainings that we will talk about in a little bit. This is a screenshot of a guidance that OASAS published last year. This is the guidance for screening, assessment, intervention, and monitoring for suicide and overdose risk in OASAS certified programs. And when we are talking about the programs that need to follow this guidance, this is a list of them. So for now with the guidance, we talk about the inpatient services, so the substance use disorder withdrawal and stabilization services, Part 816, the substance use disorder inpatient rehabilitation services, Part 818, and the residential services, the ones for youth, Part 817, the intensive residential rehabilitation services for Part 819, and the residential stabilization rehabilitation services for 820. And finally, for outpatient services, the Part 816, medically monitored outpatient services, and the Part 822, substance use disorder outpatient programs should be following this guidance as well. If you're someone listening to this talk who's working in a prevention program or another type of program, we are working on having this guidance be appropriate for your setting as well. So right now, the guidance does not require your programs to do this, but it is something that we are actively working on. So stay tuned, that'll be coming down the line. But please continue to listen because there is some interesting information here and some of that will translate over into what other programs may need to do down the line. So, and going back to the guidance in general, we did issue it on January 10th, 2022. Unfortunately, that was issued at the height of the 2022 COVID spike that we were all living with. So I think it might have gotten lost in the shuffle a little bit, but it was issued then. And there was an overdose safety planning intervention live webinar that we hosted and was facilitated by Tom McCary, LMHC, who is the CEO of Zero Overdose. And that was done on January 20th, 2022, excuse me, sorry, January 20th, 2022. The recording of this webinar of the overdose safety planning intervention is available for free on the Managed Care Technical Assistance Center of New York website, or MCTAC is what it's called. The webinar was not recorded as an OASAS Learning Thursday, so because of that, and I'm sorry for this, there are no educational credits for viewing the webinar, but there's a lot of good information about overdose safety planning, and a lot of it really parallels what we're going to talk about today for intervention, screening, monitoring for suicide risk. So the link to access the recording and an OASAS provider-specific Zero Overdose website page can be found in the guidance. So this presentation today will focus only on those parts of the guidance addressing screening, assessment, intervention, and monitoring for suicide risk. Again, because there is a whole nother webinar that focuses on overdose risk. So to start, want to do some definitions. So screening versus assessment. For the purposes of this guidance and for this presentation, screening is a process for identifying whether a patient is at risk for suicide by administering a screening instrument or asking screening questions. Screening usually takes place when an adult or adolescent is newly admitted or readmitted to an OASAS certified program. And screening can be completed by any clinical staff member who has been taught to administer screening instruments or ask screening questions. So examples of the clinical staff members who can do this include all licensed medical staff, other licensed clinical staff, but also certified or credentialed or certified staff or student interns. I think the point is clinical staff covers a lot of people, and we want a lot of people being able to do these screenings for suicide risk. For the purpose of the guidance and for this presentation, assessment is an evaluation where more detailed information is gathered about risk factors for suicide and specific recommendations to address suicide risk are determined. Assessment usually takes place as a result of responses to screening questions about suicide risk. Assessments, different from screening, should be performed by licensed practitioners working within their scope of practice. And examples of these practitioners would be licensed clinical social workers, licensed mental health counselors, psychiatric and mental health nurse practitioners, physician assistants with a certificate of added qualifications in psychiatry, psychiatrists, and psychologists. So again, licensed practitioners who have some more experience and training in assessing suicide risk. So just want to stress, a lot of people can do screening, which is great, but we do have a more focused group that we want to do a more formal assessment of suicide risk. Okay, so let's go to screening. The first part of the guidance says that you should administer an evidence-based screening instrument for co-occurring mental health conditions to all patients. Many OASAS certified programs and what is recommended in guidance that's been published in the past is that programs use the modified mini screen or the MMS. The modified mini screen is a 22-item screening instrument that captures 3 major areas of psychiatric conditions: mood disorders, anxiety disorders, and psychotic disorders. The other reason why the MMS is a great screening instrument to use is because it is available at no cost online. So if you just search the modified mini screen, it will come up and you can use it. In the modified mini screen mood disorder section, question number 4 asks, in the past month, did you think that you would be better off dead or wish you were dead? A patient who answers yes to question 4 should be screened immediately by a clinical staff member with the Columbia Suicide Severity Risk Scale or the CSSRS. A patient who answers no to question 4 does not need to be screened with the CSSRS. This is a picture of one example of this Columbia Suicide Severity Rating Scale. I did not mention or put on the slides that these are also free in the public domain. So they are easily accessed. And this is what the screening looks like. So it's very simple. It's 6 questions, technically 7, since question 6 has 2 parts. but it's very easy to follow. So first you ask questions 1 and 2. Have you wished you were dead or wished you could go to sleep and not wake up? Yes or no in the past month. And then the second question, have you had any actual thoughts of killing yourself in the past month? Yes or no. So if yes occurs to question number 2, because usually there's a yes to question 1. If you get a yes to question 2, then you move on to questions 3, 4, 5, and 6. But if someone says no to question 2, so they might say yes to question 1, but no to question 2, then you should jump down to question 6. So we're going to go through it in order. So again, if someone says yes to question 2, then you go to question 3. Have you been thinking about how you might do this? Question 4, have you had these thoughts and had some intention of acting on them? Question 5, have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out this plan? So you can see from the color coding as yes answers are given, the risk severity goes up. So the yellow is low risk. That sort of orangey red color is moderate risk and the red is high risk. So if you're going through this and people continue to say yes, by the time you get to question 5, if you've checked off question 4 and 5 as yes, you do have someone who's at high risk. If at question 3, they say no to everything else, then you have someone at moderate risk. And then again, if 1 and 2 are yes in the yellow, but everything else is no, then you have someone at low risk. And then lastly, so as we mentioned before, if someone says no to question 2, you can go directly to question 6. If you have gone through questions 3, 4, and 5, you should also do question 6. And the question is, have you done anything, started to do anything, or prepared to do anything to end your life? And there is a question. The first part is, have you done this in your lifetime? You can see the little lifetime there. And then if they say yes, then you ask, was this within the past 3 months? And if that is a yes, that means someone is at high risk. So hopefully you can see from the color coding how this can work. It is a pretty easy screen to administer. And again, there's guidance that you get on where someone falls in with risk depending on their answers. One word about adolescents. Unfortunately, the MMS is not validated for individuals under the age of 18. OASAS recommends that people use evidence-based and validated screening tools for individuals. However, the MMS is not one of them. There is a comparable adolescent version of the MMS, but unlike the one for adults, this adolescent MMS is not available in the public domain. It's not free. It costs money to use it, so a lot of programs don't use it. So the recommendation of the guidance is that the CSSRS should be administered to all adolescents to screen for suicide risk. So just go straight to the CSSRS for adolescents and not do the initial screening with the MMS. Okay, so now we're going to move on to assessment and intervention, and this is for people who are high risk. Patients who are rated by the CSSRS as high risk for suicide should meet with a licensed practitioner working within their scope of practice immediately for a suicide risk assessment. And just a reminder, we mentioned earlier that the licensed practitioners are people like licensed mental health counselors, licensed social workers, psychiatric and mental health nurse practitioners, physician assistants who have added qualifications in psychiatry, psychologists, and psychiatrists. So a patient who is rated at high risk should not be left alone while arrangements are being made for the patient to see a licensed practitioner. So really need to stay with them because at high risk, there would be a concern that something may happen imminently, and we don't want that to happen. So you need to stay with them. The licensed practitioner working within their scope of practice would then meet with the patient and determine the severity of the suicide risk and the necessary intervention. So if that licensed practitioner thinks the risk of suicide is imminent, meaning it's going to happen soon if something is not done, then program should work to arrange for the patient to be transported to an ED or a CPAP for an emergency psychiatric evaluation, because this patient who's in imminent risk of suicide may require admission to an inpatient psychiatric service for intensive treatment. If the risk for suicide as assessed, let me start that one over. If the risk of suicide as assessed by the licensed practitioner is not imminent, and the patient does not then need to go to an ED or a CPAP, the next step should be that a suicide safety plan is created collaboratively with the patient, lethal means counseling is provided, and a comprehensive mental health evaluation is scheduled within 72 hours of this initial screening and assessment, or as soon as feasible. Or if the patient already has a current mental health provider, an appointment should be made with that person within 72 hours or as soon as possible. So what happens if you're working in a program and there's no licensed practitioner available for an immediate suicide risk assessment? So you should contact your supervisor as soon as possible and make them aware of the situation. And that person really needs to go immediately to an ED or CPAP. So next step, you've got to arrange for them to be transported there for that emergency psychiatric evaluation. And again, just to remind you that patients rated as high risk should not be left alone while a supervisor is contacted or arrangements are being made for a transport to an ED or a CPAP. Now, those of you who are listening who work, say, on an inpatient service or an inpatient withdrawal or stabilization services where there is clinical staff around, obviously you're not going to send someone who's already in a hospital out to an ED or CPAP. So a lot of this leans a little bit more for people working in inpatient residential and outpatient. Apologies for not making a separate slide, but really you already have the patient in a situation where they are safe. You just need to access your licensed practitioner working within their scope of practice. So please don't send somebody who's already admitted to an inpatient withdrawal or detoxification within a hospital setting out unless you actually don't have someone to evaluate them. Okay, so that's the high risk folks. So they are the most intensive, they need the most interaction. Moderate risk is next. So patients who are rated by the CSSRS as moderate risk for suicide do not need an immediate assessment of suicide risk. So for those rated as moderate risk, same ideas as with folks with high risk for the initial interventions, create a suicide safety plan collaboratively with the patient, provide lethal means counseling, schedule a comprehensive mental health evaluation within 72 hours or as soon as feasible, or schedule an appointment with the patient's current mental health provider as soon as possible. Low risk patients who are rated by the CSSRS as low risk for suicide do not need an immediate assessment of suicide risk. They also don't need suicide safety plans. So what is usually done for them when they are rated as low risk for suicide is that they get scheduled for a comprehensive mental health evaluation within 72 hours or as soon as feasible, or scheduled with their current mental health provider as soon as possible. Next step, intervention, safety planning. Patients who are rated as high risk or moderate risk for suicide should create a Stanley Brown suicide safety plan. This also gets called safety plan or suicide safety plan. So if whatever you hear, suicide safety plan or safety plan in this talk, we are talking about this Stanley Brown suicide safety plan. And this should be created in collaboration with a clinical staff member. The safety plan does not need to be created in collaboration with a licensed practitioner. So going back to what we talked about earlier about who can do what, any clinical staff member can work on and collaboratively create a suicide safety plan with a patient. The safety plan has 6 steps. Number 1 is recognizing the warning signs of an impending suicidal crisis. Step 2 is using coping skills. Step 3, contacting others to distract from suicidal thoughts. Step 4, contacting family members or friends who may help resolve the crisis. Step 5, contacting mental health professionals or agencies. And step 6, reducing the availability of means to complete suicide. So this is what the Stanley Brown safety plan looks like. I think this looks very far away and tough to read. So what I did was I made 2 more slides where we do a bit of a close-up on the Stanley Brown safety plan. So this is the same safety plan. What I just showed you in the other slide, I just cut it into 2 so you can just see the steps. So again, the warning signs. So you would talk with the patient about what are the warning signs of a suicidal crisis or when you feel suicidal. You would write those down or have them write them down. Then you want to go to internal coping strategies. So what can the patient do to take their mind off their problems without contacting another person? So what are distracting things that they can do themselves? Can they read a book? Can they go for a walk? Can they spend time with a pet? Step 3 are people and social settings that provide distraction. So for here, you want to get the names of people and a contact number. There's space for 2 names. And then there are places you can put in as well. So maybe the park is a distracting place for someone, or going to the movies. So those would be things that you can enter in. But again, these would be directed by the patient. These are what the patients say are people in social settings that provide distraction. So let them decide what would go in there. Step 4, people whom I can ask for help during a crisis. So again, this is people. So there's names and contact numbers. Now, some of these people may be the same ones who can provide distraction when people are feeling suicidal. So some of these names may repeat, or they may be different people. Step 5 are professionals or agencies I can contact during a crisis. There's, again, room for the clinician, agency, and name, the phone, and emergency contacts, the number for the local emergency department, the emergency department address and telephone. And then the last one there, number 4, is the Suicide Prevention Lifeline phone number, which is 1-800-273-TALK or 1-800-273-8255. And then the last step is making the environment safer, which is plans for lethal means safety. So that may be things like removing sharp objects from the home, or making it more difficult to access medication if that would be a way someone might consider taking their life. We're going to talk more about lethal means counseling soon, so stay tuned on that one. So one point to make, so I tried to find a version of the suicide safety plan, or the safety plan, that actually had the new 988 suicide and crisis lifeline on it. I couldn't find one, sorry for that, but want to let you know though that there was a switch in the suicide and crisis lifeline. So it is now 988, which is an easy to remember nationwide number that was launched nationwide about a year ago from when this talk was recorded. So that was July 16th, 2022. I want to stress that that National Suicide Prevention Lifeline number, the 1-800-273-8255 or 1-800-273-TALK, is still operational. So you can call either one of those, and you can add that to the suicide safety plan. And when you call either one of those numbers, it will connect the caller to the same services. So they just want to make it easier for people, because let's face it, 1-800-273-8255 might be a little challenging to remember. 988 is not so challenging. So you will get exactly the same services. You can also text 988 if you want to contact them that way. When you contact 988 Suicide and Crisis Lifeline, it provides 24/7 access to trained crisis counselors who listen to the person, assess the problem, provide support, and connect them with mental health resources as needed and as available. The goal was really to move mental health crisis calls from 911, where the emergency dispatcher determines whether emergency medical service or EMS, fire, and/or police services are sent to the location. A lot of times the primary service dispatched by 911 to mental health crisis calls is law enforcement. And the idea is really to get law enforcement out of mental health crises and to really get the people who are trained to deal with mental health crises involved more than the police would be. So if you call 988, again, you get a different type of service than you do 911. Okay, let's jump back to some of the intervention issues. So go back to safety planning. So once you make that suicide safety plan or safety plan, the patient should get the original version of the completed safety plan, and a copy of the safety plan should be placed in the patient's medical record, so it's there. And you should have a discussion with the patient about where they will keep their safety plan and how they will retrieve it when needed. The discussion should address whether having copies of the safety plan that they can keep in several places or share with supportive people in their life would be helpful. One option for ensuring the patient has ready access to their safety plan is to change the size or format of the safety plan so it can be placed in a wallet or stored on an electric device, such as a file or a picture. Now, I imagine some people are wondering, there's got to be an app for that, right? Well, there is an app. There is a suicide safety planning app I'm going to be honest with you. I looked at them online. And the reviews were not very good. So I will mention it because I know people are probably scratching their heads going, why is she making me do paper? And I got to copy stuff and put it in a phone. So again, not that people can't use the app. Some people did find it helpful, but I was a little reluctant within the guidance to sort of support this. But I will tell you why on this Learning Thursday. But again, patients can check out the app if they want, and they may find it helpful, but some of them did not get good reviews. So I was a little reticent to say OASAS is sort of recommending this. The next step in intervention is lethal means counseling. So patients who are rated by the CSSRS as high risk or moderate risk for suicide should receive lethal means counseling from a clinical staff member as part of the suicide safety planning process. And the reasons for this is that patients may not have access to or consider multiple means of suicide when they decide to act, and will often choose a method that is readily available. Increasing the time and distance between the patient with suicidal intent and lethal means can reduce suicide risk and save lives. Lethal means counseling is also sometimes called counseling on access to lethal means, or CALM. So if you see CALM out there, it's the same thing. And there's also can be called lethal means safety counseling, or LMSC, which is actually what the Veterans Administration calls it. So all these names mean the same thing. In the guidance, we said lethal means counseling. So I'm going to use that term for this discussion. It is a patient-centered counseling strategy. It aims to promote safe behaviors by aligning evidence-based recommendations with the patient's preferences and/or values. It can be performed by any clinical staff member who has had LMC training. The trainings are online. We'll talk a little bit more about that later. But again, clinical staff members should be able to do this. The clinical staff member providing lethal means counseling expresses concern about the patient's safety and wish to keep them safe. The staff member assesses whether the patient has access to firearms, medications, either prescribed and over the counter, or other potentially lethal substances or objects. Works with the patient and their family and/or support system to limit their access to lethal means until they are no longer at elevated risk, and makes a specific plan with timelines and roles to reduce access to lethal means. So this is an example that I found online. This is from the VA, actually, the Veterans Administration, the Rocky Mountain MIRIC, which is a lengthy acronym that I will not get into, but it is a group that looks into doing research for psychiatric conditions. And they have this on their website. So just wanted to give you an example. This is not a training. I'm not telling you you should do this, but it kind of gives you a flavor of what lethal means counseling can be like. So we've got that little flag that says start. This is about medications. So the question is the medication potentially toxic? If it's no, you don't have to do other lethal means counseling around the medication. There may be other issues like access to guns or sharp objects. So again, this is focused on medication. So if you or the patient don't know if the medication is potentially toxic, you can consult with the prescriber or call the pharmacy. If that's not possible, you should just consider it toxic. To be truthful with you, I am a physician. A lot of medications are toxic. So I think in this situation, you will end up dealing with a lot of medications as a means, and trying to figure out a means to keep people safe if that's a way they would consider suicide. So now we're at the point, so we've decided that the medication is potentially toxic. So we're going to take that arrow up to the yes. And then the next question is the medication essential? So is this a daily medication for blood pressure or mental health disorders? Then the answer is yes or no, simply. So if it's a no, so let's say someone says to you, you know what, I have these antibiotics that I got 2 years ago, and there's 3 or 4 of them left, and they're just kind of hanging around my house. Then the recommendation there would be to get rid of the medication, remove it from the house. It's not necessary. It's not something anybody needs, but it could be something that someone could use in a potential suicide attempt. So let's get rid of that medication. If the medication is essential, then the goal is to increase the safety of meds stored in the household. Now I'm going to take a step back. So let's say it is a medication that someone's not using, but for some reason they can't get rid of it. I can't think of a good example, but they may not be able to get rid of it. So if they have to keep that medication in that house, even if they're not using it, then the recommendation is the same as if it's an essential medication. You want to increase the safety of meds stored in the household. So you can contact the person's provider, their prescriber, or the pharmacist, and you can discuss different issues. One is limited quantities of medication. So as a physician, when I prescribe medications to people, I can prescribe 30 days, 90 days. But when I have worked with people who had an elevated risk of suicide, I would just maybe give them a week at a time with a number of refills. So that's one way of limiting the quantities of medication that people have access to. And that quantity may not be something that would be enough to, say, seriously hurt someone or result in a death by suicide. Is there an alternative and equivalent treatment? So if they're taking one medication that may be more toxic, is there a medication that's potentially less toxic or not toxic that you can substitute out? That may not be possible, but it's something worth exploring with the provider. And then with the pharmacist, there's the issue of blister packaging of medications. So at some point, people who are listening to this may have had blister packed medications, or if you've ever brought sort of cold tablets over the counter, they come and they're in the package with the plastic, and then there's the tin foil on the back, and you got to kind of pop them out. So that's sort of an example of blister packing. And the idea behind that is that it just makes it harder to get at a number of medications at a time. So if you think about medications in a prescription bottle, or a bottle of Tylenol, or Aleve, or fill in the blank that you get over the counter, you can get a lot of pills into your system very quickly, right? They're loose in the bottle, you can just swallow them. But if they're in a blister pack, you really got to take the time to pop them out. And that may be enough to slow somebody down in an attempt to take their life, to say, maybe this isn't a good idea. Other things that you can do that I put on the bottom that they recommend, but they didn't put on the slide, is to increase the safety of meds stored in the household by locking medications in a lockbox or other secured container. Sometimes if someone lives with a significant other or a supportive friend, that person can hold the lockbox or the key and the access to it. And that way, the person who is at elevated risk for suicide does not have access to medications that they could easily take in a suicide attempt. So again, this is just an example of medication-specific lethal means safety counseling. Wanted to give you an idea of it, but it's really important that you do some training on it so you can get a better idea of it. But this is a good example too for everybody to see. So intervention and monitoring for high risk or moderate risk. So now we're going to talk about program-specific issues. So for inpatient, so this is inpatient detox, withdrawal and stabilization, and inpatient residential programs. So some of this we talked about before, but never hurts to hear it again. So you're going to develop a safety plan collaboratively with the patient. If the patient already has an existing safety plan available, that plan could be collaboratively reviewed and updated instead of, say, creating a new one. If they don't, obviously you should make a new one. You're going to provide lethal means counseling like we just discussed. And then the other pieces is developing treatment plans that include interventions to mitigate identified risk factors for suicide. So if someone says, I feel suicidal and I want to take my life when my major depression gets worse, or when I'm having a lot of panic attacks, or when I'm in the midst of a manic episode, then one intervention will be to make sure that there is treatment for the depression, the anxiety, or the manic episode. So treating an underlying psychiatric disorder that might have an effect on someone's suicide risk would be a key intervention, as an example. So again, sticking with inpatient and residential programs, you want to reassess the patient's suicide risk during their admission, so checking in with them. You want to rescreen them with the CSSRS prior to discharge to make sure that they are no longer in a high-risk category. And before they are discharged from the program, review, and if needed, revise the safety plan prior to discharge. They should be scheduled with a mental health appointment with a licensed practitioner within 72 hours of discharge or as soon as feasible. After the person is discharged, a clinical staff member should contact the patient within 24 to 72 hours to determine if their suicide risk has changed since discharge. There is a lot of research to show that the most high risk time for people to commit suicide who have been admitted to inpatient programs is in the first couple of months after discharge. So it's a critical time, and it's a good place to check in with people to see, are you feeling worse than you were before? You want to review and, if needed, revise the safety plan if there's a concern about increased suicide since discharge or something, say, has changed. Or you want to help the patient access emergency care if there is a concern about an imminent risk for suicide. So if you call them and they feel like, I'm going to do something to harm myself, you got to help them, get into emergency care as soon as possible. So if they're doing okay, their suicide risk hasn't changed, and if emergency care is not needed, then you just want to go over with them their scheduled mental health appointment and see if there's any kind of challenges to attending the appointment, and to try to resolve those. A clinical staff member should contact the patient on the day of the scheduled mental health appointment to determine if they attended. If they did not attend the appointment, the clinical staff member should try to assist in rescheduling the appointment if that is needed. And lastly, a clinical staff member should contact the patient at regular scheduled times until the patient has attended the mental health appointment or the patient requests that the contact stops. A reminder about patient confidentiality. When any patient is referred from an inpatient or residential service to outpatient substance use disorder and/or mental health treatment, a written consent must be signed by the patient according to all relevant state and federal confidentiality requirements, including 42 CFR Part 2, before the referral can be made, and any treatment records, which should include any safety plans, are sent. Now we're going to move to outpatient programs. So intervention and monitoring for high risk or moderate risk patients who are in an outpatient program. So some of this we've heard before, and this slide is actually exactly the same for inpatient and residential programs. So you'll develop a safety plan collaboratively with the patient. If the patient has an existing safety plan available, so let's say this is someone who was just discharged from inpatient or residential and they have that safety plan, then you can review the existing safety plan and update it, provide lethal means counseling, and develop treatment plans that include interventions to mitigate identified risk factors for suicide. A clinical staff member should meet with the patient frequently in person, by telephone, or by telehealth to review any use of the safety plan. So if you see someone this week and they come back next week, you want to know, hey, did you need to use your safety plan at any point? What was the situation that was going on that you did? Use it, revise that safety plan as needed, and check in with them about attendance at other scheduled mental health and other appointments to make sure they're getting the other care that they need. Patient should be contacted on the same day for a check-in if they miss a scheduled appointment with an outpatient clinic provider. You should also contact the patient if they stop engaging in mental health or substance use disorder or other treatment services, because that could be a sign that the patient is not doing well and their risk for suicide may be going up. And if you're having trouble reaching them, you can contact the individuals in the patient support system. And again, with these confidentiality issues, I want to stress with the patient's written consent if assistance is needed to keep the patient engaged in treatment or to help the patient re-engage in treatment. It is recommended that all patients in outpatient programs are screened quarterly, so every 3 months, with the CSSRS for suicide risk. A good way to remember this is you can say, so on July 13th, I met patient A for the very first time. I did their CSSRS. They were low risk. The next CSSRS will be administered on October 13th later this year. Just gonna stress patient confidentiality. If an adult or adolescent cannot receive mental health treatment at the outpatient substance use disorder treatment program and is referred instead to an outside mental health provider, a written consent must be signed by the patient according to all relevant state and federal confidentiality requirements, including 42 CFR Part 2, before the referral can be made, or any records, including any safety plans, are sent to the outside mental health provider. Some closing comments. Trust your clinical judgment, which I put a big exclamation point behind. Maybe I should have made it bigger. So if you see a patient and they're rated by the CSSRS as moderate or low risk for suicide, but something feels uncomfortable to you and you're concerned that they may be at high risk, or if someone's at low risk and you're concerned that they're at moderate risk, you can have them assessed by a licensed practitioner. If you're worried that they are high risk, then you should, and if you don't have a licensed practitioner, then you can have them transported to an ED or CPEP for an emergency psychiatric evaluation. Sometimes patients are not forthcoming about their suicide risk. So trust your judgment. If you feel something's off, never hurts to have them assessed, because you always want to err on the side of caution, because you may help prevent a suicide attempt or a death by suicide. Next closing comment, please read the guidance. All of the information reviewed in this presentation is in the guidance. There's also some very nice summary tables at the end of the guidance that provide a quick overview of screening, assessment, intervention, and monitoring for both suicide and overdose risks for inpatient, residential, and outpatient programs. And the guidance has links to great trainings. So there's trainings for suicide screening and assessment, how to complete the Stanley Brown suicide safety plan, lethal means counseling, suicide risk monitoring, and then the issues related to the overdose safety planning interventions. Again, as I mentioned, the training is on the MCTAC website, and the OASAS opioid overdose prevention training, which is on our website. The guidance can be found on the OASAS website. It is under laws and regulations. You can find it in there. You can also, which a lot of us do in New York State who work for the state, when we find it hard to find things on our own agency's website, you can go to Google and type in OASAS guidance on screening assessment, and something should pop up quite quickly, and you will get the direct link to the guidance. So apologies, it's not a little bit easier, but it's absolutely out there and you can find it. Again, the answers to most questions you may have about screening, assessment, intervention, and monitoring for suicide and overdose risk really can be found in the guidance. So please look at it first. But if you're really not sure after that, questions not answered in the guidance can be sent to the addictionmedicine@oasas.ny.gov mailbox. I want to thank you for listening to me today. And here I am again. My name is Grace Hennessy at oasas.ny.gov. I do encourage people to send any questions to the addiction medicine mailbox, because I go on vacation. I may not be in one day. And so it's better to send it there, because someone always monitors and answers emails to that mailbox. And you will get an answer sooner than, let's say, if you email me on the first day of a vacation. So again, want to thank you for your time today, and I appreciate you listening.
I want to thank Dr. Hennessy for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us, and keep up the good work.